Good afternoon. Today we'll talk about the assessment of RV size and function, RA size and function, and PA pressures. And I'm going to start now. So, right ventricular function is affected in many cardiac diseases and is an important cause for hypotension and shock. Plays a very critical role in patients with congenital heart disease, and many of these diseases involve changes in the RV structure, function, orientation, so it becomes important. Particular role, if you would, in adult congenital heart disease. Ventricular function has been associated with outcomes. If you pull any disease now in the cardiovascular system, you will see that RV function is if it's worse, that's a worse outcome for that patient, including coronary artery disease, acute and chronic heart failure, reduced EF, heart failure, preserved EF, the different valvular heart disorders, as well as in cardiomyopathic disorders. Okay. For echocardiography, it's a tomographic technique. We also do 3D. We'll talk some about that. But these are the standard views that we get the RV from, and we want to acquire them and put things together. The right ventricle is a complex structure, and you do not get to see the whole ventricle in just one view. So that's why we need to patch different views together. The first look we get is from the parasternal long axis view. The part of the RV that we see here is the RV outflow tract. You can appreciate some of the wall thickness, but it is not as crisp as you get it in the subcostal view, and is not your view that you want to go to for RV wall thickness. You can get an initial impression of the RV size from here, but is not, again, the one that we will rely on to make or break a call. Be aware of axis parasternal long views. They can give you not accurate impressions of what the RV size or function is. It is highly dependent on angulation, as I just mentioned. In this view, you can measure the diameter from the RV free wall to the junction between that base of the septum and the aorta. That dimension has an upper limits of normal of 33 millimeters. And there are some diseases, as in arrhythmogenic cardiomyopathy, where the RV is involved. And if you see a dilated outflow tract assessed in that view, that's an important metric. Another view that we can get is a view that brings in not just the RV outflow tract and the pulmonic valve, but the PA. And that gets you the long axis of the pulmonary artery, and so you would be able to see if there is infundibular disease. For example, if there is hypertrophy here or subvalvular stenosis. As in tetralogy of Fallot, look at the valve and supravalvular structures, and if you carry it upwards, you can also record the bifurcation of the pulmonary artery. We have a long axis view that I did not show here that will get you more of the PA all the way to the bifurcation. Once you get that, which is a short axis cut, and you're able to see the pulmonary artery from the valve to the bifurcation, you can measure the diameter of the pulmonary artery inner edge to inner edge. For echo, the upper limits of normal is 25 millimeters. Other imaging modalities have different cutoffs. And they differ by sex. For example, for CT, it's 27 millimeters. For MRI, it depends on the sex, and it could be anywhere from 19 to 31 millimeters. Patients with pulmonary hypertension will have pulmonary artery dilatation, and sometimes this is a clue that there is pulmonary hypertension. Of course, not the only thing. There are some efforts to relate the ratio of the PA diameter to that of the aorta as an index of pulmonary hypertension. The next view we have still from the parasternal position is the RV inflow view. And here we get to see the right atrium. We see the anterior leaflet, the septal leaflet. Initially, some thoughts were that this is the posterior leaflet, as in the 2010 guidelines. The guidelines that were published in March this year recognize that leaflet as the septal. We get the anterior wall of the RV, and you can call this the inferior wall or the wall of the right ventricle that sits on the diaphragm. In patients with coronary artery disease, depending on the distribution of where the disease is, you can see some segments that are performing and others that are not. And that's why we want to look at these walls carefully. This is a view that allows us to see the valve leaflets, and so we put color, we interrogate for the TR jet, we look at the size of the jet, we can measure vena contracta. For TR, we align with continuous wave Doppler and can get PA pressures. I say can, but it's really must. We must get the TR jet from all planes, and then we look at the highest velocity and drawing our conclusions about PA pressure. The parasternal short axis view at the level of the aortic and pulmonic valves is shown here. It's another chance to look at the tricuspid valve leaflets, anterior and septal, and therefore you can align again with TR. You look at the size of the jet, and you get the jet with continuous wave Doppler. We look at the interatrial septum. We interrogate the interatrial septum in this view. Sometimes you can see flow by color Doppler if there is a patent foramen ovale, for example. This is the view I was referring to earlier that gets you the pulmonary artery in the lung axis from the valve to the bifurcation, and we already covered what we can get with. You get very good alignments with the RVOT flow in this view, which we want to get because we want to record RVOT and calculate the stroke volume that goes through the RV outflow tract. And if there is infundibular stenosis, you want this view to get the gradient. Then we have short axis views. This is a cut at the level of the mitral valve. The right ventricle is crescent shaped here, and you get the different walls, the anterior, the lateral, and the inferior wall that sits on the diaphragm. Be careful of drawing conclusions about RV size and function from short axis views. These are highly variable and can at times give you the impression that the RV is dilated when it is not. We look for the interventricular septum. We look at its behavior during systole and diastole. We'll go in depth in that later on in this presentation, but that's an important view for that reason. Then we go to the apical window. From the apical window, we have the standard four-chamber view. We get the LV, the RV, the RA. If I do not show the free wall of the RV, it becomes difficult to comment on the RV size in this view or on the RV function. So we want to bring it in, and we have specific focused views called the RV focused view. We also have an RA focused view. I'll go into these in a short while about how to acquire them. But these focused views we rely heavily on to comment on RV size, function, do our measurements for dimensions, for fractional area change, for RV free wall strain. So an exam that lacks the RV focused view is a deficient exam, not good to submit. Then we have the low parasternal view. This view brings in the free wall of the RV and is another chance to look at these segments, but we do not really rely on that view to make measurements. You can get impressions about the RV performance in that view, and you can align with the TR jet and the flow across the tricuspid valve. You can also interrogate the interatrial septum. If you're doing a bubble study, you can get that low parasternal view and look at the behavior of the bubbles from that view. This is a 5-chamber view that brings in the aorta, and frequently in that view you will get the moderator band. Nothing special about the moderator band except to say when you are doing measurements for the area, you include it in the cavity. You do not trace around it. It becomes part of the cavity, not of the RV free wall. That's a view that brings in the coronary sinus. It is a modified view from the focus view that we just said. It can help you look at flows from the sinus into the RA, as well as the tricuspid valve and all of the other things. Can be at times more challenging to obtain. The subcostal view is a very valuable view for patients where we do not have good windows, no parasternal and no apical windows. So now we rely on this. Not good to make conclusions about size and function accurately, maybe grossly, if you would. We measure the RV free wall thickness in that subcostal view. You can use 2D, you can use a mode. Remember that you see the interatrial septum, and so you interrogate it with color. You can also do a bubble study in that view if you would. We can look at the tricuspid valve, put color, get TR jet from that view. Then again, from that location, we get something similar to the parasternal short axis, if you would, and here it shows you the valves, the pulmonic, the aortic. You get both RV inflow and RV outflow. You can see part of the pulmonary artery. You can get very good alignments with flow in the RV outflow tract from that view. So you see there is a lot that can be and should be included in the exam that we can rely on to see the different segments of this right ventricle. Now the RV focused view. How do we get the RV focused view? This is taken from the guidelines this year. You start with an apical position, okay? And then you gradually rotate, guided by the view that you will see. From the apical position, I will see the LV and the RV. As I am rotating, I will see a larger and larger right ventricle. I keep rotating till I get the maximum minor dimension of the right ventricle, taking care not to foreshorten the RV and still show the apex. Frequently, this means you need to do a slight lateral displacement of the probe together with an upward tilt towards the right ventricle. And that's the view that we get. This is the view where I can do the RV lung axis, where I can do the minor dimension at the base, at the mid-level, and these should be reproducible. If people do not rotate all the way or incomplete, then you will get different sizes of the RV, and that puts the challenge why some patients, the RV size looks different, say, from previous studies. There is also an RA-focused view. So for the RA-focused view, we start with the RV-focused view, and once I've shown the maximum dimension of that RV, I gradually tilt the probe upward towards the sternum and a little bit medially, and that will show you the maximum size of the RA. This is the view that we want to do the RA volumes, area, dimensions from. Okay. So now we talked about acquisition. Let's talk quickly about the blood supply of the different regions of the right ventricle. So as you know, the right coronary artery is the main source of blood supply to the right ventricle. The interventricular septum is a bit different. We'll tackle it towards the end. But the right coronary artery gives branches. These are the branches that provide blood supply to the different segments of the RV. The main one that supplies the RV anterior free wall, and the lateral wall as well, is the acute marginal branch of the right coronary artery. The conus branch is a very small branch that comes off proximally from the right coronary artery and supplies the RV outflow tract. If you're doing angiography, you want to be careful not to get into that artery. If you do and you inject, you can trigger serious ventricular arrhythmias. The inferior wall of the RV, or the wall that sits on the diaphragm, in addition to the posterior interventricular septum, gets its blood supply from the posterior descending branch of the right coronary artery.
whereas the moderator band, the RV apex, and of course the LV apex and the distal septum get their blood supply from the septal perforator branches of the left anterior descending coronary artery. It is reasonable to expect that well-trained echocardiographers know the blood supply of the different regions of the right ventricle, and when problems are seen in different segments, what is the artery that is involved. We talk here about the measurement of RV wall thickness, similar to the left ventricle. If afterload increases on the right side, the RV wall thickness increases. This is at first. Later on, it moves from that concentric stage, if you would, to a stage where the ventricle dilates, and we're talking about eccentric hypertrophy. You can measure it from 2D, you can measure it from M mode. Where you measure it is distal to the, or just distal to the tips of the tricuspid valve. You do not include the fat pad if you see fat, and it's just the wall, and it is at end diastole. It's an end diastolic, not an end systolic measurement, similar to the left side. And the upper limits of normal is 5 millimeters. These are the measurements that we obtained from the RV focused view. So the first measurement is the what you can refer to as a major or basal, not really major. The major is the lung axis. This is the basal dimension, and the basal dimension is taken from the endocardium of the septum to the endocardium of the RV free wall. It is endocardium to endocardium. I do not, when I measure, I do not include the thickness itself in that measurement of the diameter, because it's an index of the size of the cavity. The upper limits of normal is 4.1 millimeters, and if you index it to size, this is the only measurement in the guidelines where dimensions are indexed to size, is 2.4 per millimeter squared, centimeter per millimeter squared. The other measurement is midway in the ventricle, so it's between the basal measurement and the apex, and the upper limits here is 3.5. The lung axis is taken from the base all the way to the apex. That's why it is important not to foreshorten. If you foreshorten, you will get a smaller dimension. Is less than 8.2 centimeters. The one that I would say should be measured and reported is that basal dimension. Then another thing we can measure as an index of RV function, and remember is not a global index of RV function because the RV has an outflow portion that is not seen in this view, is the RV fractional area change. So we start tracing from that lateral tricuspid annulus edge along the endocardium of the free wall, all the way to the apex, then along the interventricular septum to the medial side of the tricuspid annulus. PAPS, trabeculae, if for whatever reason you see the moderator band, all of that is part of the cavity. We do that at end diastole and end systole. The lower limits of normal is 35%. You need to memorize that number. Less than that is abnormal. The upper limits of an end diastolic area in the new guidelines is not dependent, or a single value is used for both sexes. Previous guidelines recognize that there is a sex difference in what the upper limits of normal is. For this one, it's 25, end diastolic, index 14. For the end systolic is 14, and indexed is 8. As the ventricular function gets worse, as you expect, the ventricle dilates, and so the area increases, and the fractional area change drops. If I don't see endocardium well, of course, my measurements will be wrong. So I do not do this measurement just for the sake of doing it. I have to see it, and ideally we set from the RV focused view. We talked about the interventricular septum and the behavior of the interventricular septum. There is an eccentricity index. If you read into the pulmonary hypertension literature, a lot of the risk scores, the more recent ones, include this eccentricity index. So let's talk about it. Theoretically, as shown in that image, you can do it for both the RV and the LV. The one that is more in these scores is really the LV, not the RV eccentricity index. What is that index? It's the ratio of the anterior-posterior diameter, that line in yellow, to the septal to lateral diameter shown in red. When the right ventricle increases in size, it pushes the interventricular septum towards the left ventricle, and so the side-to-side measurement becomes less and less. More than 1 or 1.1 is recognized as abnormal. If you see a septum that is flat in diastole but not systole, this is volume overload. If you see a septum that is flat in systole, this is pressure overload. A septum that is flat in both systole and diastole is pressure overload with or without volume overload. Again, as you can suspect or imagine, if I get off-axis cuts of the LV and the RV, I can make the septum look D-shaped like the way you are seeing in this view. That would be a bit challenging to also accompany a small LV. So be careful of the orientation and what the plan, the imaging plane is, and put this in context with other findings in the study. Causes of RV volume overload are, we're not going to say mild or moderate. These will be severe lesions usually: tricuspid regurg, pulmonic regurg, atrial septal defect, anomalous pulmonary venous return. Pressure overload, high RV systolic pressure. So either pulmonary hypertension or significant degrees of pulmonary stenosis, be it supravalvular, valvular, or subvalvular. Moving to also indices of RV function, we touched about the fractional area change. This is another index, the dP/dt. We talked about, or you may have heard that, about the mitral regurg jet. Similar to the mitral regurgitation jet, we get a tricuspid regurg jet. I need to get a complete envelope, but at the very least, the ascending limb has to be clear. Then I want to change my sweep speed. Because I am measuring a time interval, I want these time spaces not to be crowded together but spread out. So I use a high sweep speed, 200 millimeters per second. And then dP/dt is change in pressure over change in time. We fix the time points or the pressure points that we are looking at their change. 2 and 1 millimeter mercury. You do the modified Bernoulli, this corresponds to a pressure difference of 16 minus 4 or 12. And so all you have to do is divide that 12, which is a fixed number now in the numerator, by the time interval between when the velocity was 1 and when the velocity is 2 meters per second. The lower limits of normal is 400 millimeter mercury per second. It's not done routinely, really, but the way I use it is more of a qualitative index of function. If you see a jet that is rising very slowly, this is usually an indicator that the RV systolic performance is depressed. You can also do a similar approach for the descending limb to get a feel for the negative dP/dt, but it hasn't really gained much steam, and there is only 1 or 2 studies at best where this measurement was compared with the invasive gold standard. So this is more of a qualitative thing. You don't need to sort of do the actual calculation. TAPC is tricuspid annular plane systolic displacement, is a measurement that has gained ground, I guess, in recent years as an index of RV systolic function. What it does is it measures the vertical or the longitudinal displacement of that tricuspid annular plane. The idea is if the ventricle has a good function, it shortens, So the lung axis gets shorter, and there will be a good degree of displacement. That's the simple thought behind it. The challenge with it, aside from technical issues, and we'll get into these in a short while, is that the extent of displacement also may happen because of rotation of the ventricle. And so if there is a rotation that can make it within normal range, a ventricular function can be depressed, and you end up with a normal TAPC. The other thing to remember, this is just the lung axis function of the ventricle. It is true that later stages of RV dysfunction will be accompanied by a reduced TAPC, perhaps not earlier on. Whereas a measurement as RVEF by 3D or the fractional area change take into account also the radial thickening that is happening, and that contributes to the ejection of blood out of that right ventricle. The lower limits of normal is around 17, and we'll talk about that. Some investigators have combined this or have looked at TAPC as an index of systolic function and tried to relate it to the pulmonary artery pressure or afterload to look at RV-PA uncoupling. The idea of coupling and uncoupling is important. The question is this the best index of RV systolic function that detects problems or not? Before we leave it, we need good alignment with the flow. So if there is not a good alignment, we will underestimate TAPC. That's a challenge. In the post-operative setting, it is not uncommon to see a reduction in TAPC, even though RV systolic function may not be depressed. Similar to the TAPC, we can measure, instead of the actual displacement in millimeters, say, or in centimeters, you can measure the rate of displacement. So now we're looking at the velocity. This is with color-coded tissue Doppler. We no longer use that, but there was a time when it was used. We rely more on the pulse wave spectral envelope. And the idea, again, is if there is a good lung axis function, we will have a high velocity. As the function gets less, the velocity gets less. The same limitations for TAPC, including angulation and underestimation, come into play when you look at the systolic velocity. Notice that if you do a time velocity integral here, so I measure that area, its velocity multiplied by time, I should get a very similar value to the TAPC in millimeters that I get by M mode. Then come another index of RV systolic function, which is RV strain. I'm showing here one of the early validation studies where strain was measured by sonomicrometry against echocardiographic measurements. You see a good correlation. And we can measure strain for each of these segments, the 3 segments on the free wall as well as the 3 segments on the septum. Strain can also be used to look at RV-PA uncoupling. The idea is for any given PA pressure, a patient who ends up with a lower strain value, absolute value, to a given PA pressure has a worse RV function. The one that is the best indicator of RV function is the free wall strain, not the septum. Why? Because the septum is shared by the LV. So if I want to isolate the RV as much as I can, I want to go to the free wall strain. And we want to see all these 3 segments. So when we report strain, we report RV free wall strain rather than RV global strain. The available ultrasound platforms will give you both and will give you the TAPC at the same set of data once the system is working on them, but the one we want to report is the RV free wall strain. There is a lot of data showing that RV free wall strain is associated with outcomes in many patient populations, but particularly in patients with pulmonary hypertension. Then comes the 3D RV volumes. remember that the RV has different components. We look at them in different views, but if we want to combine them together, we want to do 3D. So when you get the 3D, you depend on the different views, and they are put together to end up with a 3D volume. For 3D volume proper acquisitions, we want to get a higher frame rate always, which means you make your sector as when you are acquiring smaller and your depth less, not deep. That's one thing. The other thing, you ask the patient to hold their breath, perhaps 4 to 6 cycles if they can, cardiac cycles, so you avoid stitch artifacts. Of all the measurements that are done, when compared against another standard like CMR, the RV volumes and the RV-EF correlate the best with the CMR volumes and EF, albeit there is a consistent underestimation of RV volumes by echocardiography. So now let us shift gears and talk about RA measurements. We want the RA-focused view. We talked about how to acquire it. You can measure that lung axis from the middle of the tricuspid annular plane all the way to the roof of the right atrium. And then we can measure the septal to lateral from the mid-interventricular interatrial septum to the mid-RA free wall. This should not exceed 52, 53 millimeters. This should not exceed 42 millimeters. While I sort of presented in the guidelines, we rely more on RA area and RA volumes. So for area, you are doing a planimetry for that area from above, from the lateral tricuspid annular plane along the free wall of the RA, the superior wall, down the interatrial septum to the medial side. The upper limits of normal is 19 centimeters squared. And then we can do RA volumes, both by 2D using the multiple discs method or the area length method, or we can do it by RA volumes by 3D. There are less data, as you expect, for what is normal for RA volumes by 3D compared to 2D. And unless you have good RA volumes data set by 3D, you can end up underestimating the true size. To emphasize the major differences, and we'll get into more numbers towards the end of this presentation that you should memorize, the upper limits of normal by the area length method is larger than that by the multiple disc method, 33 ml per meter squared versus 30 ml per meter squared with no sex distinction. For the RA volumes by 3D, the upper limits of normal is 42 mLs per meter squared. The RA minimum volume, which occurs at end diastole after the RA contracts, is maximum. The upper limits of normal for that minimum volume is 20 mLs per meter squared. Okay, these are the numbers we were talking about, and they are a lot. The ones that you need to memorize is the area and the maximum volume index. We use more frequently the multiple disc method as opposed to the area length method, and so less than 30 is normal, and 30 or above is abnormal, could be mild enlargement, up to 36 mLs, more than 36, less than 41, that's moderate, more than 41 is severe. For fellows and attendings who do the reporting, one should follow this so we are all consistent. It doesn't matter who looks at the study. If it is measured at 35, we should all call it mild enlargement as opposed to mild to moderate or upper limits, for example. Another thing that we can do with the right atrium that hasn't gained steam and is not recommended, but for you to know about, is RA strain. Why not much with RA strain? Because the normal ranges are all over the place, and so we cannot sort of isolate values and say below than this it is abnormal. But similar to the LA, you have a reservoir strain, you have a contractile or pump strain, And the difference between them is the conduit strain. There are data that in patients with pulmonary hypertension, reservoir strain is worse, lower, and that this index is associated with more clinical events. But that's all you need to know about RA strain. Let's talk about myocardial performance index and index of RV systolic function. So the index is defined by the following: the sum of isovolumic relaxation time and contraction time divided by ejection time. One way of looking at it is how efficient or how much time is wasted without doing something, without ejecting blood. So the longer these time intervals relative to the ejection time, the worse the ventricular performance or efficiency. A smaller value means these time intervals compared to the ejection time are shorter. So to get isovolumic relaxation time and isovolumic contraction time. These time intervals, as you know, for the relaxation time, it's the time between pulmonic valve closure and tricuspid valve opening. For the contraction time, it's the time between tricuspid valve closure and pulmonic valve opening. Tricuspid inflow and RVOT flow are not acquired in the same plane, cannot be acquired in the same plane, which means we use different views and different cardiac cycles. So we have to be careful and look at the heart rate and the RR intervals when we do this measurement. So ejection time is obtained from the RV outflow tract. So in the parasternal short axis view, for example, and it's the time between onset of flow and end of flow. And then I go to the tricuspid inflow and I measure the time between the end of the A velocity for one cardiac cycle and the onset of E velocity for the other cardiac cycle. And that includes all time intervals. Subtract from that the ejection time, you end up with the numerator. Another quick way of doing it is to get the total duration of tricuspid regurgitation. Tricuspid regurg occurs during isovolumic contraction, ejection time, and relaxation time. If I subtract from the total duration of TR the ejection time, then I end up with that numerator. The lower limits or the upper limits of normal, because here higher values is worse function, when you do it by these pulse wave Doppler techniques, is 0.4. To circumvent this issue, if I am doing multiple cycles and multiple measurements, what about I just go to the tricuspid velocity signals by pulse wave Doppler, and here I get the ejection velocity, isovolumic contraction, isovolumic relaxation, and everything is obtained from the same cardiac cycle. It cuts that issue. So the ejection time is the time between the onset and end of the systolic ejection velocity. It excludes the isovolumic contraction time. We get the isovolumic contraction time between the onset of the QRS complex and the onset of S velocity, between that red line and that yellow line. Isovolumic relaxation is between the end of the S velocity and the onset of the E prime velocity. So now I have these two time intervals directly measured, and I have the ejection time. The upper limits of normal for this is 0.55. So as you see, they are not comparable. They relate to one another with a modest correlation. When one goes longer, the other is also going to be longer, but one does not substitute for the other. Now that we talked about the conceptual background and how it is measured, let us talk about its limitations as an index of function. If I look at this and say this is an index of systolic function, and you take a look at its determinants, you can readily see that all time intervals will depend on heart rate. Also, these time intervals depend on whether there is conduction abnormalities. Somebody with a bundle branch block will have a prolonged QRS and a long isovolumic contraction time. A third variable in this equation is the isovolumic relaxation time. Somebody who has a high RA pressure, their isovolumic relaxation time can shorter. So someone could be in bad RV function, high RAP, and that performance index, also referred to as stay index, may not catch that change. So in general, we do not sort of put heavy weight on it, but it's an important concept and measurement to know how it is obtained, what affects it, and what are the ranges for normal values. Let's talk about a measurement that we look on for pulmonary hypertension, and this is taken from the 25 guidelines. So the normal morphology of RVOT flow is rather rounded, as you see here. As pulmonary artery pressures rise, the peak velocity will happen earlier and earlier in systole, and it becomes more or less triangular. Then with good degree of pulmonary hypertension, high pulmonary vascular resistance, you can see this splitting or W waveform, which is thought to be related to reflection of pulse waves through the pulmonary circulation. And finally, when the RV goes down, you end up with a very short acceleration time and a really small time velocity integral because the stroke volume is now down. So that's an evolution of severity of pulmonary hypertension. As its name implies, acceleration time is the time from onset of flow to peak flow. The shorter that time interval, the higher the PA pressure. So inverse correlation between them, and the upper limits of normal is or the lower limits of normal is 105 milliseconds. Again, it depends on heart rate like other time intervals. We're going to sort of talk from now till the end, except for the last 3 slides, on pulmonary hypertension. So the definition of pulmonary hypertension was first 25, now it is 20 millimeters mercury. And the goal of looking at an echo for someone referred with that diagnosis, of course, is to recognize that they have pulmonary hypertension. And then you want to be able to say, is this cardiac or non-cardiac from the data that you have? And finally, what is the RA and RV compensation? However, the most reliable distinction between cardiac and non-cardiac etiologies is not going to sit with imaging only. You want to look at clinical findings, lab data. There are diseases that cause pulmonary hypertension, as you know, by different mechanisms. Imaging, pulmonary imaging, looking at the pulmonary parenchyma and vasculature, echo findings, and certainly right heart cath. Okay. So we'll talk about how to estimate each of these pressures, systolic, diastolic, mean pressure. We can look at the etiology, be it cardiac or non-cardiac. The non-cardiac is, of course, a challenge for us. And then we've already talked about RA and RV function. When you see RA dilatation, when you see an RV that gets worse, when you see an effusion, all of these are indicators or are associated with worse clinical outcomes. We acquire TR-jet by continuous wave Doppler from multiple windows. Has to be multiple windows. We want to estimate RA pressure, and therefore we look at the inferior vena cava diameter in the subcostal views. We look at its behavior with spontaneous respiration and with sniffing, and we look at the size of the hepatic veins and hepatic vein flow. If this is a case that is referred because it says pulmonary hypertension, unless otherwise asked not to, we want to use agitated saline. Sometimes you can use blood saline. Sometimes you can use ultrasound enhancing agents for other reasons like LV endocardial border definition, and then go back and see what the TR-jet looks like. So we end up with a complete envelope. Very high feasibility of getting TR in patients who have pulmonary hypertension. And remember, we talked about interventricular septum and behavior. So if I see a septum flat systole, during systole, I have to be on the alert. What is the actual PA pressure, and try to make sure that the peak TR was indeed captured. This is a jet that is not suitable for any measurement. Do not attempt that. So incomplete. This is a jet where we can see the peak, and we do the modified Bernoulli equation as we talked earlier during the year. And so here it is 4v squared. The peak velocity is 3.6. So there is a PA systolic of at least 52 without adding any RA pressure. How about PA diastolic pressure? We rely on that signal, or we can get that signal from the parasternal short axis view. You can also get it from the subcostal view, as we talked earlier during this presentation. We need the RAP, and so we want IVC and hepatic veins. Again, if you use saline or ultrasound enhancing agents, this signal can be enhanced. Feasible in more than 70% of patients with pulmonary hypertension. The velocity we rely on for PA diastolic is the end diastolic velocity of the signal. This is the end diastolic velocity. So if we do the modified Bernoulli equation here, and we have an end diastolic velocity of roughly 2, we know that the PA diastolic is at least 16. Because these velocities are usually not going to be very high velocities. Of course, there are patients where it could be high. A lot of the accuracy of the PA diastolic pressure estimation relies on how accurate you are in estimating RAP. And we need to remember that. The mean PA pressure can be calculated by different equations. The easiest is the diastolic plus 1/3 pulse pressure, which means I have to get both signals. Another approach is to get the 4 multiplied by the peak velocity. So not the end diastolic, but the peak velocity of the PR jet. I'll show you the slide in a moment. You can add to that RAP, and then we can also remember the acceleration time and the inverse relation. So that's one of the regression equations that is used. There are many other regression equations that have been published. In general, these are probably less reliable than a direct calculation, provided you have good assessment of RAP and complete TR and PR jets. We'll not dwell much on these. This is the peak velocity for the PR, and if we do the 4v squared, we know it is at least 46 without adding any RAP, and it's a solid signal. Solid cold, there is pulmonary significant degree of pulmonary hypertension in this patient. A high PA pressure could be elevated because stroke volume is high, as in, say, very young, healthy individuals, young athletes in particular can have high PA pressures because of a large stroke volume, but the pulmonary vascular resistance itself is not elevated. In comparison to someone who, say, has group 1 pulmonary hypertension where PVR is up, and depending on the course of the disease and what happens, say, with exercise, both components may come into play. So what I'm trying to say is a PA pressure by itself is not enough to call pulmonary hypertension. We want to know what the PVR is. The units for it are units of pressure over flow. You can see them here. They were incorrectly entered in the guidelines, but these are the SI units. People also use the Wood units. Less than 1.5 is normal, more than 2 is abnormal. And in patients with non-cardiac pulmonary hypertension, the PVR is up. One approximation that was advocated by the echo community is instead of a complex or the more complete expression to get PA pressures, let's get the peak TR velocity as a surrogate for pressure and the RVOT flow as a surrogate for the cardiac output. You readily recognize that these are sort of not perfect expressions, right? Here we need the RVOT diameter as well to get flow, and of course PA systolic is not equal to the mean PA pressure minus wedge pressure, which is what is entered in the numerator to get pulmonary vascular resistance. A ratio that is more than 0.38 is 100% specific, but look for huge increase in the pulmonary vascular resistance. A ratio less than 0.12 to 0.15 normal PVR, in between, which is a big range, it could be anywhere. In patients with adult congenital heart disease and pulmonary hypertension, this expression was found to be least reliable. Let's move on. Oops. inferior vena cava diameter is what we rely on for RAP estimation, and what happens with inspiration, either spontaneous or with sniffing. The upper panel, someone with a normal RAP, the lower panel, a dilated vein, dilated hepatic veins, doesn't do anything with sniffing, markedly elevated RAP. This is our first line, the one to go to. There is an inverse relation between the collapse index, how much the inferior vena cava diameter decreases with inspiration, against mean right atrial pressure. The solid circles are patients who are not on mechanical ventilation, and you see a significant, rather decent association, albeit a standard error of estimate of 4.1 millimeters mercury. In comparison, if you look at patients who are on mechanical ventilation, the open circles, there is no correlation. So when someone is on mechanical ventilation, we do not rely on IVC collapse. Okay. The limitations are in patients' respiratory distress, cannot do good breathing and cannot do sniffing. Mechanical ventilation only useful if you end up with a diameter at most 12 millimeter. In that scenario, RAP is less than 10. More than that may be associated with normal RAP or elevated RAP, so not enough. Of course, post-op, somebody doesn't have subcostal views, cannot rely on it. We get tricuspid inflow, and our lab has that in our routine acquisition protocol. We also get hepatic vein flows, and we want to get multiple cycles because flows on the right side vary with respiration. Impaired relaxation pattern has been described. Restrictive filling pattern has been described with a very high E to A ratio, short decel time. Short decel time on the right side is usually less than 120 millisecond. A ratio more than 2 is considered restrictive. Normal, healthy, young individuals can have these values. So we are talking about these values in a dilated, depressed RV. Significant association between the E to A ratio, but quite a degree of spread as well. So by itself, need to put it in the proper clinical context before relying on it. Hepatic vein flow, similar to pulmonary vein flow. As RAP goes up, the proportion of forward flow during systole becomes less relative to diastolic flow. Inverse relation between what we call the systolic filling fraction, or how much flow occurs in systole relative to the total flow duration. This is a significant association and works in patients who are on mechanical ventilation as well. Example of a patient with a very markedly elevated RV and diastolic pressure is shown here. It has a long duration and a very high velocity. This is a patient with a high RV EDP. Systolic reversals can be recorded, and if they are consistent with every cardiac cycle in someone in sinus rhythm, it is severe TR or moderate to severe TR till proven otherwise. High specificity in excess of 85-87%. There are limitations in patients with pericardial compression syndromes. They can affect the ratios and the relations between systolic diastolic flows, tricuspid, significant tricuspid valve disease, arrhythmias, heart transplant recipients, and of course if you don't have subcostal views. Okay. It will not advance, maybe because of the time. Cut me. Can you guys come help me here? In the back? He's not doing it. Oh, there it is, it went, just because you were trying. The isovolumic relaxation time, we touched bases on it earlier. It can be acquired from that RV free wall at the tricuspid annulus. And the higher the PA pressure, the shorter the isovolumic relaxation time. Time between end of systolic ejection velocity and onset of E velocity. We can do E to E prime ratio also on the right side, relates with RAP. The higher the RAP, the higher the ratio. Also, the higher the E to E prime ratio on the right side, the worse the outcome. This is shown in a patient here with pulmonary hypertension, but also shown in patients without pulmonary hypertension. Similar to the other signals, there are situations that pose challenge. as in pericardial disease, where that velocity may be may be reduced, the lateral free wall velocity, early diastolic because of pericardial adhesions, tricuspid valve disease, and arrhythmias, and of course absent apical views. This is a quick approach based on IVC and hepatic veins, and this is taken from the 2025 guidelines document. It's a long algorithm, but it's really simple. Basically, if you have an RAP, so if you have an IVC that is less than 21 centimeter in diameter, 21 millimeter in diameter, or at most 21, with more than 50% collapse, RAP is normal. You give a range 0 to 5. The recommendation is, rather than giving a range, please give a single value. So we can say a value in the middle, 3. The other side of it is, if you have an IVC that is more than 2.1 centimeters with less than 50% collapse with sniffing, then RAP here is elevated, 10 to 20, and use a value in the middle, 15. If the IVC is more than 25 millimeters, then this is an RAP more than 25. What happens if you end up with one or the other? One or the other meaning the diameter is less or at most 2.1 centimeters, but the collapse is less than 50%, and vice versa. A diameter that is increased, but a collapse is 50% or more. Here you go to other findings as restrictive RV filling, the hepatic vein flow, the tricuspid E to E prime ratio, more than 6. And then if these indicators are present, you shift it towards the high RAP. If they are not present, you shift it towards the low RAP. And if you don't have any of that, or you don't know, I cannot proceed any further, then use a value in the middle, which is 8 millimeters mercury. Example for pulmonary hypertension is shown here. You see now the eccentric degree of remodeling with dilated RV along with increased RV mass. Very high PA systolic, very high PA diastolic. The end diastolic here is 3.5. And the flow pattern is predominant diastolic flow in the hepatic veins consistent with a high RAP. We sometimes get these views where the RV is markedly enlarged and it pushes the LV. This, when you end up with that position, or when you end up with that view, it's difficult to align with flows on the left side. So I have to reposition my transducer to get mitral inflow and annular velocities. We talked about the flat septum. Question that comes frequently is cardiac versus non-cardiac pulmonary hypertension. The 2025 guidelines go into that and try to make it more accessible. Mitral inflow and annular velocities are a big help by themselves. If somebody has high PA pressures and increased pulmonary vascular resistance, the left side is normal, say group 1. The typical inflow pattern is a low E, high A, so an impaired relaxation pattern. If you look at the septal velocities, they can be reduced because the septum is contributed for, in terms of function, by the RV. So we rely here on the lateral side velocities, and here the velocity is pretty normal. So that patient likely has non-cardiac, not cardiac pulmonary hypertension. In comparison, this is a flow pattern where there is pseudo-normal, and the velocities are, when you do the E to E prime ratio, it's elevated. And this is work from this lab showing the group of patients with primary pulmonary hypertension against secondary. The E to E prime ratios are elevated here in both cases. The higher the pressure, the higher the ratio. So in absolute perfect scenario, which is not always what we get, if this is, and we'll say the easiest one is group 1 pulmonary hypertension, you would see reduced LV filling, an LV that is small in size, an LA that is small in size. I would see, if it has reached the stage where the RV is decompensated, a right ventricle that's dilated, a flat septum in systole. I can see also tricuspid annular dilatation, varying severity of tricuspid regurg. On the left side, LV mass index normal. LA volume, as we mentioned earlier, normal or reduced. PA diameter should be dilated, and the eccentricity index the way you see it. The opposite of that is for cardiac or group 2 pulmonary hypertension. The reason I said group 1 and not the other groups, because, for example, patients with obstructive airway disease can be advanced in age and can have risk factors for heart failure preserved EF, and they may very well have heart failure preserved EF, and their pulmonary hypertension is a mix, cardiac and non-cardiac. So there may be situations where we cannot make that distinction reliably by echo, and in all cases where we are saying this is a significant degree of pulmonary hypertension, it is not unreasonable to proceed to right heart cath to look at the mean PA pressure, PA pulmonary capillary wedge pressure gradient, as well as the pulmonary vascular resistance. And these are sort of hemodynamic and Doppler findings. Reduced LA strain, enlarged LA goes with a cardiac etiology as opposed with to a non-cardiac etiology. This is a slide that has all the numbers that speak about RV size. This is one that you want to memorize. The thickness of less than 0.5 centimeters, you want to memorize it. The end systolic area and index, the end diastolic area and index. For 3D volumes, we don't usually do them. You need to remember the RVEF. We'll come to that in the next view. If you are going to do RVOT diameters, and these measurements will carry more importance when you're suspicious or when you see a case referred with an actual diagnosis of arrhythmogenic cardiomyopathy. Fractional area change at least 35%, RVEF at least 45%, free wall strain at least 20%. As mentioned earlier, we do not rely much on the global strain. TAPSE 1.7, systolic velocity 9.5. We also do not rely much on the myocardial performance index. Last is the diastolic function indices. If you say part of the diastolic dysfunction is the RA enlarges, so then I want to look at RA size, and that's why I put the RA volume. IV size and its change, that's an indicator of RA pressure, hepatic vein flow, IVRT of the RV, less than 73 milliseconds. We showed you how to get it from tissue Doppler, and then E to A ratio. If you have less than 0.8 or more than 2, that's abnormal. E to E prime ratio more than 6, abnormal. AD cell time less than 120 or longer than 230 is abnormal. Granted, these vary by heart rate, age, and sex. Thank you.